Ladies and gentlemen, my name is Stephen Cross. I'm a PGY1 pharmacy resident here at Erlanger, and I'm here today to present to you my CE project, which is a review of the 2020 American Diabetes Association, or ADA, Standards of Care. Our objectives for today will discuss and highlight changes in the 2020 ADA diabetes care standards. We'll classify disease states impacting medication therapy selection in the diabetic patient, and we'll identify compelling indications of use for specific hypoglycemic drug therapies, and will illustrate differences in outpatient and inpatient treatment goals for patients with diabetes. So first I wanted to get into why I chose this as my continuing education project. So the American Diabetes Association released the new Standards of Care update in January of 2020. This update addressed results of more recent randomized controlled trials, but more than anything, it shifted away from the original thought of this has to be A1C driven for diabetes care, and wanted to start looking at overall the patient themselves. What other issues do they have going on? Because a lot of these newer agents can help to treat not only diabetes, but some of these other compelling indications for care. But first, I wanted to look at where we came from. So these are the 2017 American Diabetes Association guidelines. You may notice that monotherapy starts out with metformin and lifestyle management, and then moves to metformin plus lifestyle management plus an agent, and then triple therapy moves to metformin plus that original agent plus another agent. There's not really a ton of guidance as to which agents you should use, just what their hypoglycemia risk is or what their weight loss benefit is. What's really important to point out here, though, is that up at the top, you have A1C greater than 9 or greater than or equal to 9, you want to consider dual therapy. If their A1C is greater than or equal to 10, then you want to consider combination injectable therapy. There's not really a lot of guidance as to what you should choose, just that you should choose something. And a lot of that was addressed with this newer update. So this is the 2020 American Diabetes Association guidelines. There's a lot here, but what's important to note is that first-line therapy is still metformin and comprehensive lifestyle management. After that, though, it moves into indicators of high risk or established ASCVD, CKD, or heart failure. If your patient doesn't have this, then you can start looking at your A1C goal, which can help to be dictated by, is your patient having issues with weight loss? Is your patient having issues affording their medications? Are they a high hypoglycemia risk? And then they give suggestions as to which agents are best to help mitigate those. But if they do have one of these compelling indications, then you want to help to tailor their diabetes therapy to these indications, regardless of what their A1C is at baseline. So the main indications that we're looking at are ASCVD, or cardiovascular disease, and heart failure, or HF, and CKD, or chronic kidney disease. And a lot of these have had new data emerge here recently to help with guiding these therapies as to and why they've moved so far up this algorithm. So ASCVD is the one we're going to look at first. Established cardiovascular disease or high-risk ASCVD patients is what we're mainly looking at, but you may notice that two of the agents have shown more benefit than others, and this is your GLP-1s or your SGLT2s. But first, let's get into what is ASCVD and how does it affect your diabetic patient. So ASCVD affects roughly 33% of your, or a third of your diabetic patients. It affects more males than females and is responsible for a little bit more than half of your deaths in diabetic patients. As well, it's going to be a high-cost issue for your diabetic patient. A patient with ASCVD is going to cost nearly twice as much yearly in comparison to a patient without ASCVD. So not only are you affecting them mentally and physically with these drug therapies, but you're also having a large financial benefit or a large financial burden on top of that. in patients with ASCVD, their first line in weight loss, and their second line in patients with heart failure and chronic kidney disease. While there isn't a lot of data for these disease states, there's actually such a strong cardiovascular benefit from them that you'll notice that they have moved up the guidelines for these other indications. For your GLP-1s, mainly your adverse effects that you're looking at are nausea and abdominal pain. This is mainly due to their mechanism of action that we'll get into in the next couple of slides. As well, patients have an increased risk of pancreatitis with these agents, so you'll want to monitor lipid levels at the beginning. You'll want to be cautious to start these in patients with elevated triglycerides at baseline. And finally, if they have a history of or current medullary cancer, then these agents are contraindicated. While this is a rare adverse effect, it is one that you have to keep in mind because it is something that increases with use of these agents. So you'll notice here that GLP-1s, this mainly is just to show comparative efficacy of the agents. This is placebo-adjusted trials, and this is a slide that is this is a picture that is a couple of years old, so it does not have every available GLP-1 agent listed. What is important to take away from this, though, is that your GLP comparative efficacy is going to be around 1% of an A1C reduction for your diabetic patients. So how does GLP-1 work? So it's made in the GI tract, and then as it moves through, and then as the receptors are agonized, we'll start to see effects in a clockwise motion from here. So we'll start in the brain. First off, you'll see decreased appetite, which is going to be one of the main drivers for weight loss in your diabetic patients. As well as that's going to play in with the stomach, you'll see delayed gastric emptying. In the pancreas, you'll see increased insulin secretion, and in the liver, you'll see increased insulin sensitivity, or in the muscle, you'll see increased insulin sensitivity. In the liver, you'll have decreased glucose production, and one of the main things that we're wanting to talk about today, in the heart, you'll see an actual increase in cardiac output, as well as some cardioprotective measures from these agents alone. As you can see, there are a number of different GLP-1 agents that are available on the market. So I just wanted to take some time out to kind of point out what is going on with these, what you can do with them, and which one should you choose for your patients. So you'll notice there's a lot of different dosing options for these. You have BID, you have daily, but most of your newer agents have moved towards a weekly dosing schedule, which is very convenient for patients. Just having to take these agents once a week, you'll get at least a 1% reduction in A1C, you'll see some weight loss, and you'll see some cardiovascular benefit. As well, you have a weight loss effect. Most of these will start around 2 kilograms, and then go up from there, just dependent upon the actual agent itself. As well, you may notice that there's not a lot of creatinine clearance adjustment for these. There's actually only 3 agents, and 2 of them are the exenatide agents, the other one, lixisenatide, that have a creatinine clearance adjustment or a non-recommendation of use. The rest of these are safe to use in any creatinine clearance as well as any hepatic insufficiency. Some really cool things about some of these agents, though. So Victoza is a newer one to the market. It is your TennCare preferred agent. As well, they have a different version of this that's name brand Saxenda. Saxenda is specifically indicated for weight loss. It is a higher dose. So you will see some A1C reduction with this, but as well you'll also see more, okay, just making sure. But as well you'll also see more of a weight loss from this agent in and of itself. Some of your other newer agents, you may notice down at the bottom, you have semaglutide listed twice. So this one's actually something new that's came to market. The top one, Ozempic, is an injectable form. The bottom one, Rybelsus, is actually the first oral agent to market. There's a number of different doses for these. Just know that for these agents, you'll want to start lower and then titrate up slowly. This just helps your patient to recognize what's going on with them, as well. It kind of helps to curb some of that nausea and issues with delayed gastric emptying. Gives them time to get used to that before you up the dose to a full treatment dose. You'll notice that these two agents at the bottom are also your best for weight loss. They do have the highest numbers. These are over a 26-week period, and newer studies that have came out that have studied these for longer have noticed that this weight has dropped off and stayed off. So using these in combination with your standard of therapy of diet and exercise will help them to lose more weight overall over time. Something that is important to point out for these two agents, though, so you do have a 14 milligram strength of Rybelsus and a 1 milligram strength of Ozempic. These are not equivalent. So between these two agents, the 1 milligram of Ozempic is higher and more potent than your 14 milligram of Rybelsus. So if you do have a patient that needs tighter glucose control, it's something that you can keep in your back pocket, that you can switch these fairly easily from the oral tablet to the injection without really having to lose any of the other benefits. As well, I wanted to mention some of the trial comparisons for these. So you have a number of these that have looked at cardiovascular benefits of these different agents. Your main ones that I want to point out, so you may notice your semaglutide agents, once again, are at the top. This is a fantastic agent in and of itself. There's not a lot of side effects. You get great cardiovascular benefits. So you looked at a 3-point MACE out of these, which looked at a composite of non-fatal stroke, non-fatal myocardial infarction, and cardiovascular death. In and of itself, these were tops in comparison to placebo. And you wanted to, so these generally, unless you just can't get insurance to pay for them for some reason, should be the agents that we're going with first. But after that, you still do see some benefit from the other GLP-1s. So if you can't get somebody to pay for it, that doesn't mean that you should just give up on the agent altogether. Liraglutide, which is still your TennCare preferred agent, still has a 13% reduction. As well, you still see that weight loss benefit from the agent, so that will help to lower these lower some of these cardiovascular risk factors as well. Also, dulaglutide is another one that shows some cardiovascular benefit. Really cool thing that they've done in this new guideline update is they've added a hierarchy of these agents. This is a combination of weight loss and cardiovascular benefit. So your hierarchy goes semaglutide, followed by liraglutide, and then dulaglutide. After that, it goes lixisenatide and exenatide. These are mainly interchangeable, just because while they do have weight loss benefit, they did not show cardiovascular benefit in trials. So what should you know about GLP-1s? So these are your second-line agent after metformin for patients with a history of ASCVD. You will see best overall agent for weight loss out of these. A really cool thing about the weekly agents, if a patient misses a dose, they have a 72-hour window to make up that dose. So if they are normally on Sundays, as long as they take it by the end of the day Tuesday, they should be able to, or there's not going to be an interruption or a lapse in therapy. As well, if it's something comes up or a patient needs to switch what day of the week they take these, you've got room to play around with there. Keep in mind these do increase insulin sensitivity, so if a patient is on insulin or a sulfonylurea, you want to consider a dose reduction with these agents. And as mentioned earlier, you don't want to use them if they have a history of or current thyroid or medullary cancer. Last, you want to keep in mind these do delay gastric emptying. So in patients that have diabetes with gastroparesis, you'll want to use these in caution, maybe titrate up slower, just to make sure that your patient's going to tolerate this new agent and that delayed gastric emptying on top of this potential gastroparesis. So next, I wanted to move into sodium glucose cotransporter 2 inhibitors, or SGLT2s. So these are second line and after your metformin and your GLP-1. More commonly, you'll see these because of their mechanism of action, their adverse effects. You'll see a lot of urinary tract infections. And as well, there's a controversial increased risk of amputation. So one of the trials showed, the CANVAS trial, showed patients that were on canagliflozin did have an increased risk of amputation in comparison to patients on placebo. This is not something that's been able to be easily replicated, and the reason that they added this contraindication for known peripheral vascular disease is it seemed patients who already had peripheral vascular disease who were given canagliflozin did have an increased risk of amputation, so they kind of played that into there, but it's not something that we've been able to easily reproduce over time. So how do SGLT2s work? After the kidney has filtered out glucose, SGLT2s work by inhibiting, or SGLT2 inhibitors work by stopping SGLT2, which filters out, or filters roughly 90% of the glucose that the nephron has filtered out back into the bloodstream and allows it to where it overrides SGLT1, which filters out the remaining 10% and helps to dump out that excess glucose in the urine, which is why you see an increased incidence of urinary tract infections with these agents. Some of the really cool effects that you'll see out of these, though, so not only do you see decreased plasma glucose and A1C, but where they're eliminating that sugar from their bloodstream, you'll see a decreased body weight. You'll see some increased insulin sensitivity as well, where there's not as much glucose in the system. The pancreas itself will have decreased insulin secretion. One of the main things that you do want to keep an eye on, though, is that these can increase LDL in your diabetic patients. Most of your diabetic patients over the age of 40 should already be on a statin, but if you have someone that's younger that's trying one of these agents, it's something you'll want to monitor consistently with them just to make sure that you're not pushing that too high and needing to put them on a statin early. I know some providers now will automatically start them on a statin regardless of age if you're starting them on one of these agents, just to kind of cover yourself, make sure that you're getting both of these for these patients. So there are only 4 SGLT2 inhibitors on the market. So you have canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin. As well, there are a number of combination agents on the market, which is very convenient for your patients, especially because all of these have some form that is combined with metformin, so you can use that to simplify their overall medication regimen, make it a little bit more convenient for them. Some important things to point out. So canagliflozin has your lowest creatinine clearance cutoff out of all of these agents at 30 to 60. You do have to dose reduce them. If they were on 300, you want to dose reduce them to 100 milligrams. But these are also once daily agents. It's not a huge deal to do that. As well, your creatinine clearance under 45 for dapagliflozin and empagliflozin, which is our formulary agent, use is not recommended, or continuing these agents is not recommended if it's going to be something that's consistent for them. Another thing to point out, ertugliflozin is currently in trials to show CV benefit, but has not currently shown CV benefit, and is one that will move towards, is working towards this as we speak. So if you do have one that you're choosing, you may want to stay away from that one for just a little bit, just until we get that data to support that. You have 3 main trials that we're looking at here today for your cardiovascular benefit for SGLT2s. You have EMPA-REG, CANVAS, and DECLARE-TIMI 58. All of these looked at cardiovascular benefit, and as well they did notice as a secondary outcome in DECLARE-TIMI 58 that dapagliflozin showed a reduction in heart failure admissions. All of these did look at a 3-point MACE similar to the GLP-1s, and it compared themselves against placebo. You'll notice that the two older trials, the EMPA-REG as well as CANVAS, did show a higher reduction of placebo, or a higher reduction with placebo. in comparison to the DECLARE-TIMI trial, but that extra look at the reduction in heart failure admissions pushed it towards another indication that we'll go into a little bit more in detail here in the next few slides. So what should you know about SGLT2s? So these are second line in patients after GLP-1s and metformins with cardiovascular disease. Canagliflozin is actually indicated in patients the creatinine clearance of less than 30, but that's only if they're continuing the agent. So if you have them on canagliflozin and the chronic kidney disease worsens, you can actually continue this agent, moving it pretty far up the algorithm. And even though there was the issue with potential amputations in the past, it's not something that we've been able to reproduce. It has scared some providers away from it, but it's not something that should keep you from using these agents in patients in the future. As well, there is the increased risk of UTI, so you need to monitor your patients for that, and you'll want to watch renal function in the other agents. So real quick, AG is a 49-year-old male presenting to clinic with a past medical history pertinent for MI, CABG, type 2 diabetes mellitus, and hypertension. His diabetes regimen includes metformin, 1,000 milligrams PO BID, insulin glargine, 30 units at bedtime. Patient is struggling with weight loss and is looking to see if there are any issues we can make to help him, or if there are any changes that we can make to help him. A1C this visit is 8.6, and the patient has issues remembering to take his medications. He has new insurance and is fine with adding on another injection if that helps him reach his goal. So which agent should we start him on? Mike said A. And that's right. So we have a patient with a known cardiovascular disease. He's struggling with weight loss, so you're going to see benefit of it there. You're starting him at a low dose as well so that you can titrate him up to make sure that he's going to tolerate it. He has issues remembering to take his medications. This one's not only weekly, but you have that 72-hour window to where you can redose him, or where he can, if he misses his dose, he can take it later. He has new insurance, and so he shouldn't have issues paying for it, and he doesn't mind adding on another injection. Two, you want to keep in mind, though, that since he is on an insulin therapy, you'll want to potentially dose reduce that, or at least have him test more often to make sure that you aren't making him hypoglycemic with adding on semaglutide. So we talked about the ASCVD side. So next, I want to move into the heart failure or CKD side. What you're mainly looking at here for your heart failure patients, most of the trials have looked at patients with a left ventricular ejection fraction of less than 45, so mainly your HFrEF patients. For CKD, you're specifically looking at GFR from 30 to 60, or a urine albumin creatinine ratio of greater than 3. So most of these trials have started looking at SGLT2s. These side benefits that you started noticing in the CANVAS, the IMPA-REG, and the DECLARE-TIMI 58 trials started to see that there's actually some benefit with these with SGLT2s. And as mentioned before, GLP-1s don't have this data for CKD or heart failure patients, but they have such a strong cardiovascular benefit that they've also moved higher up into the algorithm for these patients. So first, let's go into chronic kidney disease and diabetes. Chronic kidney disease affects roughly 23% of your diabetics. This was back in 2013, and this number is expected to increase. Did not see newer data for this at that time, though. Diabetes accounts for roughly 49% of your new CKD diagnoses, and 45% of your diabetic patients are on hemodialysis if they have a CKD diagnosis. As mentioned before, with CVD or cardiovascular disease, this is a higher cost overall to the patient. While not as high as cardiovascular disease, it still is an extra $5,000 on average a year. And as mentioned in the last slide, SGLT2s are emerging as first-line agents for these patients. Your current standards of care for CKD as to manage secondary risk factors. So you're wanting to look at A1C control in your diabetic patients with SGLT2s. Linagliptin or Tradjenta, another formulary agent of ours, has good data in patients with CKD as there's not a creatinine clearance adjustment for this agent. A lot of these patients will be on insulin just because it's easier to control. You're not having to worry about any major changes for the patient in their kidney function with this, and it's overall just a well-established agent for patients. And metformin, normally a first line, and unfortunately probably won't be used in your CKD patients because once their creatinine clearance or GFR gets below 45, the use of this agent is not recommended. For blood pressure, you're mainly looking at ACE inhibitors or ARBs. They had as well a recommendation from both the American Diabetes Association as well as the American Heart Association, which had if you're looking at a patient who's not showing signs of volume depletion, but their serum creatinine is rising, it's not necessarily a reason according to these organizations, to discontinue their their ACE or their ARB therapy. So you need to look at not just the laboratory marker, but how is the patient doing on this agent. So how did SGLT2s get to so high up on the CKD algorithm? The main one that we looked at is canagliflozin. So canagliflozin in renal outcomes and diabetic neuropathy, or the CREDENCE trial, was inspired by a subgroup analysis from Canvas. This looked at a 4-point MACE of end-stage renal disease, doubling of baseline serum creatinine, renal mortality, and cardiovascular mortality. They saw a roughly 30% hazard ratio reduction for your primary endpoint, which equated into a 4% average risk reduction in comparison to placebo, meaning that roughly that you needed to treat anywhere from 24 to 25 patients in a year's time to see one of these, or to see one reduction in these events. Overall, pretty good numbers for these. It is important to note that these were mainly patients who were CKD stage 2 or 3 at baseline, so they did have some established, but it's not ones that were completely without any kidney issues or anything that at baseline. So next I wanted to move into heart failure. So heart failure and diabetes in 2019 mainly affects your female population. Men with diabetes have a 2-fold increased risk for heart failure, and as well women with diabetes have roughly a 5-fold increased risk. 44% of your patients have been hospitalized for heart failure have diabetes. SGLT2s also moved up the algorithm here because they have a diuretic-like effect. So as mentioned earlier, they're going to take that excess glucose and take it out in the urine. Well, if they don't, it's going to make your patient have to urinate more if they have excess glucose. There is a cap on this, which is why you see that 2-kilogram weight loss maximum. Mainly, once a patient starts to lose more than 200 grams of sugar a day through their urine, it's when you start to see this slow down. But as long as they have that excess, you're going to see not only the benefit in these agents with glucose loss, but you're going to see it with fluid loss as well, which is a lot of how we're theorizing that this is helping in heart failure patients. So for your standards of care for heart failure, a lot of this is going to be similar to the standards of care for CKD, as well as the standards of care for cardiovascular disease. You're going to want to control blood pressure, so keep it less than 130/80. ACEs and ARBs still first line. As well, most of these patients will be on either, most likely a beta blocker for some kind of rate control. You'll want to, of course, use caution in these because they do mask some of your symptoms of hypoglycemia. Metformin is first line, but there is some data that is currently being disputed as to this can be or should be stopped in patients with unstable or hospitalized heart failure. There was some reports back in the early 2000s of this increasing your risk of lactic acidosis, but it's in one trial that came out in 2018 as well as another that came out in 2019, both looked at this and saw that this wasn't as big of an issue as we originally thought, and isn't necessarily a reason for patients with metformin or patient to have their metformin held. So how did SGLT2s get so high up in the algorithm for heart failure? Main one is going to be DAPA-HF. So this trial looked at dapagliflozin in patients with heart failure and reduced ejection fraction. This was inspired by a subgroup analysis of the IMPREG, DECLARE, TIMI-58, and CREDENCE trials. Then the composite on this was worsening heart failure or cardiovascular death. We saw a 4.9% average risk reduction in this agent versus placebo, which equated to roughly 20 patients needed to be treated for 2 years' time to see a reduction in one of these events. It is important to note for this one, most of your patients were New York Heart Association Class 2, so they weren't in severe or they weren't your most severe heart failure patients, but that was present at baseline. So while this agent is well established in moderate heart failure, you may not see as big of benefits in patients with severe. And finally, to wrap up this side, I wanted to move more into outpatient goals of care. So you may have some patients that come in, and as opposed to telling you what their A1C goal is, which for a long time has been a flat 7, they may tell you a little bit higher of a number. A lot of this is going to be patient specific. I liked the way that they broke this down on this picture because the right side has modifiable versus non-modifiable risk factors. So you're wanting to look at things like disease duration, life expectancy for your patient, important comorbidities, as well what resources are available for them, what can they afford, what's available for these patients in general, as to what your A1C goal that you're shooting for is and how we're treating them. As well, something you're wanting to look at baseline for your new diabetic patients, especially with higher A1Cs, is to see is there any issues with diabetic retinopathy. So there was a meta-analysis that came out in 2018 that looked at patients with higher A1Cs who had baseline diabetic retinopathy. Patients who had rapid A1C reduction, which was defined as an A1C greater than 10 at baseline that dropped to goal of 7, saw a 10 to 20% increase in incidence of diabetic retinopathy, which is a non-reversible side effect of this, and it's something that you'll definitely want to keep in mind for your patients. So make sure as they're coming in, you're setting a realistic goal for them. You're taking into account the entire patient, as well you're looking into what else is going on with them, especially if you're evaluating not only their eyes, their heart, their kidneys, all that. So now I wanted to move into another question. LR is a 58-year-old female presenting today for a follow-up visit. She's concerned that because of her new nephrologist said she would need to adjust many of her diabetes medications because of her new diagnosis of chronic kidney disease. Her creatinine clearance is 28. Which diabetes medications should be adjusted and or discontinued? So on this, we're looking at metformin will discontinue because her creatinine clearance is now below 28. She's below that 45 threshold where it's not recommended, and it's an absolute contraindication below 30. As well, canagliflozin was at 300, so she can continue this agent. It just needs to be dose adjusted to 100 milligrams a day. Finally, I wanted to move into more of a combination of outpatient and inpatient agent. So now we'll look at insulin therapy. So insulin's place in therapy is, per the guidelines, if injectable therapy is needed to reduce A1C. So you'll mainly see this in a lot of patients who are very high A1C at baseline, or they're already on a GLP-1 or a GLP-1 is contraindicated, or if a patient prefers it, to take injections to try and control their overall insulin, or if they're very proactive with their diabetes therapy. A1C lowering effect is going to be variable dependent upon dose of insulin, but as mentioned before, you're just wanting to make sure that you're evaluating your patient consistently, especially at least on a yearly basis, to evaluate for effects of diabetic retinopathy and severe major side effects for this one. So it will counter some of your work that you're doing with your GLP-1 or your SGLT2 agents and weight gain, and obviously if you're taking insulin, you can have some incidence of hypoglycemia. So there are a number of insulin preparations. I actually didn't list them all here, but I wanted to go over some of your major ones that we'll see out in the field. Humalog, Novolog, and Apidra are your rapid-acting insulins. Novolog, you may notice, is as our formulary agent, but while it does not have the fastest peak of all three of these agents, it does have the longest effective duration and maximal duration. As well, that's one that you'll see all of these agents are ones that you'll see that need to be taken with or around a meal, which is an easy intervention to make, especially if your patient's not eating. So what should you do if your patient's not eating? Well, then you have regular insulin. So regular insulin is great for patients, especially who are on continuous feeds, TPN or something to that extent. This agent is one that, as opposed to having the peaks and valleys that you would see with Novolog, dosing it 4 to 6 times a day, you'll get more consistent coverage. And as opposed to having to take it with a meal, it's one that you can monitor every 4 to 6 hours to make sure that the patient's blood sugar is responding appropriately. As well, we have NPH, or the Humulin or Novolin insulins. So these are normally dosed twice a day, but if you're having a patient that is having more issues with daytime hyperglycemia or a nighttime hypoglycemia, this is a fantastic agent because it's going to fall off before that next dose is due. So if they're having more issues at a certain time of day, this one is a great agent to use. As well, there is a lot of data showing that this one has less overall nocturnal hypoglycemia in comparison to some of your longer-acting basal agents like Lantus, Levemir, that are 24-hour agents, just because it does have a peak and it does start to taper off as opposed to these peakless insulins, which get up to a certain point and then just kind of ride out for the remainder of their duration. Next, I wanted to move into your longer-acting insulins. So we have Lantus, which has a number of brand names. You have Lantus and Basaglar, as well as Toujeo, which is a U300 agent, which also has great evidence in nocturnal hypoglycemia. But I wanted to focus more today on Levemir, as this is our formulary agent. So Levemir is dose-dependent in its effective duration and maximal duration. If you have a patient that's larger, say that you have a 160-kilogram patient that's getting 10 units of Levemir once a day and you're still having issues controlling, well, it's probably because that Levemir is falling off. A lot of the times you'll see our patients here that are dosed twice daily on Levemir, and this is a big reason behind that. So these smaller doses of Levemir can be given more often to help control hyperglycemia at a better rate. And finally, there's insulin degludec, which is an ultra-long-acting insulin, which is great for use in outpatient. Once again, kind of like the GLP-1 therapies. If you have a patient that is forgetful, that misses doses, or anything to that extent, this is an agent that lasts for 42 hours. So if they don't do their dose every day, it's one that you want to encourage them to do that, but you're not going to see as big of an impact if you're giving them this dose in comparison to, say, something like Levemir or Lantus. And finally, I wanted to move into the premixed insulins, which are your long-acting as well as short-acting. You won't really see these used as often. These have fallen out of favor. Mainly you'll see these in patients who are having trouble affording two separate insulins, or maybe long-time diabetics who want to cut down on their total number of shots a day. It's important to note here that these do have faster peaks than your basal insulins, but they also have longer duration than your short-acting insulins, which is why the dosing on these is so different in comparison to the other agents. So how do I take these agents and convert them to other agents? We'll have a lot of patients who are coming in from outside facilities or from the field who are on these strange agents, or who are on these agents that we don't have available. Well, the good news is most of these insulins that are available are one-to-one. So the only exception to this, if you have a patient that's on twice daily NPH and you're converting them to glargine, you'll use 80% of the NPH dose. As well, if you have a patient that's on Toujeo and you're converting them to once daily, the U300, and you're converting them to U100 glargine, you'll use 80% of the total dose. As well, that's a general good rule of thumb if you're having to convert from one insulin to the other, or as well if you're converting a patient from an insulin drip to basal bolus with insulin regimen. You'll want to use 80% of that just because you know what they were controlled on, and as opposed to potentially putting them at risk for hypoglycemia, you can start them here and kind of give them a little bit more leeway into how they'll work, or how they'll go back into a normal insulin dosing regimen. So speaking of basal bolus, we have the RABBIT-2 trial, which is a big reason as to why we do basal bolus insulin inside the hospital. This one looked at basal bolus compared with just sliding scale regular insulin alone, and using a target blood glucose of 70 to 140, which you may note is lower than our normal target blood glucose. This one showed better blood glucose control with a basal bolus insulin regimen in comparison to just the sliding scale alone. While they did have a similar incidence of hypoglycemia, which is defined as a blood glucose less than 60, they had a different incidence of hyperglycemia. They had much better control out of patients who were on a basal bolus in comparison to a sliding scale insulin regimen. So not every patient is going to fit into this mold, though. There are some patients who you can get away with just a sliding scale insulin regimen, but if you're having ones that are persistently hyperglycemic, this may be your first step as opposed to just putting them on the sliding scale. You need to figure out a basal bolus regimen that will work best for them. So I mentioned a few seconds ago that we have that was a lower overall goal for blood glucose, which is they had at 70 to 140. Our normal target blood glucose for patients within the hospital is 140 to 180. This is considered important because you're not at as high a risk of hypoglycemia with these agents, but you're also not as at high a risk of hyperglycemia. They do have recommendations in the guidelines for your patients who are either NPO or poor oral intake comparison to patients who are eating normal meals. But once again, it's going to be, as opposed to just putting them on basal plus bolus if they're NPO, you're going to want to take a look at the patient overall, see how they're tolerating their insulin. You may not want to give a patient who's not eating basal insulin whenever they don't need it. So it's something that's important to keep in mind, that even though the liver's still working, they're still making the glucose, and there could still be an increase in blood sugar. You want to make sure that you're taking into account that they may not need these full doses. So finally, I wanted to move into the key takeaways for this overall presentation. So your overall treatment goals should always take patient-specific factors into account. So for cardiovascular disease, we're looking at metformin, GLP-1s, and SGLT2s. For cardiovascular disease, you're looking at SGLT2s, GLP-1s, and as well linagliptin. but preferably an agent with some sort of benefit in this disease state, as well as some cardiovascular benefit. And for heart failure, you're looking at metformin, SGLT2s, and GLP-1s. So another important takeaway from this new guideline update is to not be afraid to offer insulin early. That's still your best bang for the buck agent for patients with elevated A1Cs, but as mentioned before, you're wanting to make sure that you're screening their eyes as well as their kidneys to make sure that there's not any excess issues that are coming along with this rapid A1C lowering. And you want to make sure that you're setting realistic goals with the patient. So if they have an A1C of 15, you don't want to put them immediately at 7. You may want to take a stepwise approach to this, working maybe, okay, let's shoot for less than 10, or let's shoot for 9 or 10 with your next visit. And then at 3 months, okay, now let's shoot for 7. Just making sure that it's something that's easily attained, or that's actually attainable for your patient. As well, you're wanting to make sure that it's not something that's going to discourage them and make them give up altogether. So from the next couple of slides, I put my references for the GLP-1 trials as well as the SGLT2 trials. And I'll take any questions. Thank you. A lot of the trials that have looked, So the question was, if you have a patient with type 1 diabetes, would you see the same, or would you see similar benefits for adding these agents onto a type 1 diabetic as you would a type 2 diabetic? And a lot of these studies, unfortunately, have not looked at these in type 1 diabetes. There have been some separate studies to look at GLP-1s and SGLT2s as add-on therapies to type 1 diabetics, but you don't really see the same benefit, and as well, they're mainly just risk, or you're mainly seeing more risk as opposed to benefit with these agents in type 1 diabetics in comparison to type 2.
Is it appropriate to continue these in an inpatient setting? Does the benefit justify the cost?
So the question was, for patients who are already on SGLT2s or GLP-1s at home, does the benefit outweigh the cost of continuing these inpatient? And a lot of these, it's going to vary patient to patient. Your SGLT2s, we do have these available on formulary. And it's something that really this is a long-term benefit as opposed to a short-term reduction. So for the time being in the hospital, if they're only going to be in for a short amount of time, may just be beneficial to just put them on insulin for the time being. And while it's not easy, there's nothing available to convert patients from GLP-1s or SGLT2s in the inpatient setting. Just monitor them for that time being and then restart these agents at discharge. Though with the SGLT2s being available as an inpatient agent, it's something that you can, if a patient has heart failure or has CKD, it is something that we have available here to potentially trial them on and see if they're going to tolerate it while they're inpatient before we send them out with a prescription for them.